Welcome back to the Friendly Circle Berlin Monday workshop. Uh, Today, our workshop title is The Four Horsemen Navigating the Inextricable Connection Between Trauma, Shame, Mental Health, and Addiction. In the next 90 minutes, we'll explore how these four powerful phenomena, while distinct, are deeply interconnected in ways that shape our lives and recovery journeys. And it's my pleasure to introduce our speaker, Dan Griffin. Dan is an internationally recognized author and thought leader in the world of addiction recovery, whose work centers on accepting our imperfections and understanding the conditioning that forms who we are. Since May of 1994, Dan has been in long-term recovery from addiction himself, a journey that has brought him face to face with profound pain and extraordinary joy. His personal experience navigating addiction, mental health challenges, and trauma have given him a sense of purpose he never could have imagined. Dan brings not only his expertise, but his lived experience to help us understand these complex connections in ways that can transform our own healing paths. His compassionate approach reminds us that while these issues may be part of our story, they need not define us. Well, thank you so much, Dan, for offering this workshop to our community. Really appreciate you, and I will now turn it over to you. Thanks,
Thank you so
Dan.
much, Patrick. Thank you for having me. It's been really a pleasure not only getting to know you, but being introduced to this community, who I know I have several friends and colleagues who have also connected with this group: Claudia Black, Jamie Marich, and Alan Berger. They all suggested that I connect. And this presentation, my usual audience for this is a professional, quote unquote, group in addictions and mental health. I try to steer it a little bit away from that, but this may still feel academic at times. But I still hope that you all, if you're not in a professional in the field, that you find ways to apply this to your own personal recovery. So my company is Griffin Recovery Enterprises. One of our mantras is we teach you what you should have learned in school. And where that comes from is that most of my topics are still things, for whatever reason, are still things that most people don't talk about. Most people are definitely not learning about in school. And it's the same stuff that I like to joke that the same things and same kind of mentality and attitude that used to get me kicked out of class and kicked out of schools now gets me invited around the world to talk to people. So I start this presentation with a little story that many of you may be familiar with. It's The Blind Men and the Elephant. It comes out of the Eastern cultures, and it's simply 8 blind men come towards this object, and they are each have a hand on a different part of this object. And as they begin describing it to each other, they say, for instance, one has a hand on a tail and says, "Oh, I know what this is. It's a snake. It's got to be a snake," right? And then the other one has his hand on like the body of the elephant, this huge, huge, rough body, and has a hand. He's like, "I know what this is. It's a wall. It's got to be a wall." And they go and they all have a hand on a different part of the elephant. And there's different versions of this story. There's the kind of more cynical, pessimistic version, and that's the more commonly stated one. And in that one, the blind men cannot agree on anything. They disagree with each other about what is true and what's actually happening, and they kill each other. That's one version. I like the other version, which is there's another point where they start to talk to each other, and rather treating what they're experiencing as the only truth, they begin to say, oh, I have my hand here, you have your hand here, you have your hand here. And together they're able to put it together that it's an elephant. In many ways, I mean, you could say that's some things that's happening in our society, but it's certainly what's happening in addictions, in the addictions world. So the hands that we have right now, for many, many years, people had their hand on mental health. And it was like, it's mental health. Then they had their hands on addiction. Then John Bradshaw came along and he was like, oh, but there's this underlying thing, this undertow of stuff called shame. And he wasn't the only one. Virginia Satir and others, talked about shame, and shame goes back, but Bradshaw really blew it up. And then all of a sudden, people started talking about this thing called trauma. And now trauma is the thing, right? People have their hand on trauma, and now trauma is the truth. Or is it? And that's one of the questions, I guess you could say, that I bring to this presentation. So this is a little bit about me. One, as Patrick mentioned, I'm a man in long-term 12-step recovery. With bipolar, trauma survivor, and I've done extensive work on my own shame. Tons and tons of shame. Somebody mentioned that they were ACA. I love ACA. I love AA. I love all the 12-step programs, and but the ones that have really helped me personally, Al-Anon, ACA, AA, have just been absolutely wonderful and critical. Understanding trauma is absolutely a game changer. Shame is slippery and sneaky and prolongs our suffering long, long into our recovery. Addictive diseases and mental health disorders are primary disorders. And that there is a spiritual component to all of this that nobody quite understands, despite anybody who says they do. And many don't want to acknowledge or even discuss. And the last thing that I'm going to say, and I really try to come from this place, is I have no answers. I treat this as an inquiry out of curiosity. I treat it as something that this is my observation. I want to talk about the whole elephant. I'm really not interested in the folks who only have their hand on one thing and are calling that truth. And there's a little too much of that right now, as far as I'm concerned. And I'll talk about that. But from the perspective of having any definitive answers, I don't really know that I bring that. So are they all primary? Addiction, mental health, trauma, shame? If anybody's on here who may be familiar with some of my work, I use this concept called the water all the time it's just about these two fish in the bottom of the ocean. Another fish swims up and says, hey guys, how's the water? And swims off. And the two fish look at each other and they say, what the hell is water? And that's us, right? Like, we are the fish in the water, and the water is reality. And the reality is all the stuff that we are immersed in that we don't necessarily even pay attention to it, because we are born into the water, and we begin to be immersed in it long before we can really think as actively, as consciously as we do once we become adults. But we're always taking it in, and we're taking in the ideas, and we're taking in other people's ideas, and we're introjecting all of this idea of reality. And people are telling us what reality is and what reality isn't, and what's true and what's not true, and what's okay and what's not okay. And that's the water, because we don't necessarily see it. We just live in it. over and over and over again. And a lot of my talks, usually at this point, I go into a whole nother piece because a lot of my work has been around gender conditioning, which I'll get to. But the whole concept of water also, there's this whole aspect of what what the water is like that we live in. And see, the thing is that I think a lot of us would love to say that the water is just, oh yeah, reality is just amazing. Reality is beautiful. But the truth is, there are a lot of toxins in the water. What are the toxins in the water? Well, the toxins in the water are things like addiction and trauma and shame and mental health, the four things that we're going to talk about today. But the other things in the addiction are in the water are racism, homophobia, sexism, just implicit bias, all the bias we have against each other, all of the judgments we have against each other, the assumptions that we make about people. Oh, he looks a certain way, he must be this. Oh, he's talking about this, this must mean that. And the way that we shortcut our attempts to truly connect with one another by judging and assessing and doing all the things that we do. But those are the toxins in the water that we take in, right? So I'm going to talk about the four pieces a little bit. I'm going to watch my time as well. So the first thing is shame. Shame is a very interesting thing. If you're familiar with Pia Melody and the work she's done around shame, and then of course Brene Brown and John Bradshaw, I mean, like those are probably three of the biggest pioneers of shame, and there's many people who have done stuff around shame. But for instance, Brene Brown doesn't believe in healthy shame, at least as far as I, her original work, and she didn't really kind of buy into that concept. But Bradshaw and Pia Melody do support that idea. I'm not saying one is right or one is wrong, but it makes sense to me that there is a thing that we call healthy shame, that at the core of our being a part of the human community is this thing called shame that helps us navigate the ideas of appropriate behavior. It's what keeps us from all just, walking naked into the boardroom during a meeting. It's the thing that just keeps us from yelling profanities in the middle of somebody's share in a 12-step meeting. It's those things. It's that healthy shame, that ability to be like, oh, I'm a part of this community and I want to remain a part of this community. And so there are certain things that I'm going to do, right? So that's part of the healthy shame. But then there's the unhealthy shame, or what people could call toxic shame. And the classic definition that goes back to, I don't even know who it goes back to. It goes back quite a ways. It's not that I have made a mistake, it's that I am a mistake. That when I make a mistake, there is this visceral reaction that I have that says, like, there's something wrong with me that I made a mistake. And of course, that ties into the perfectionism, that ties into so many things, but it's this feeling, this visceral feeling that we get that's rooted oftentimes in our childhood. And it may be at the root of it all. I mean, it certainly has been my experience that I was sober a long time and I had incredible shame that I was not dealing with. And it's the hardest to deal with because the essence of shame tells us that we can't talk about it. I feel ashamed. So I don't want to tell you about this. And now I'm part of the 12-step community and I have all this shame that I still haven't dealt with, and I don't want to tell you this. Or I have new experiences. Like for me, like a big thing about shame is my career was taking off at a certain point. I was doing really well. My mental health was not doing well, but I couldn't quite tell. And I ended up having a really negative experience. I used to be a senior fellow at a particular organization. That was a very prestigious appointment of mine. I was given this incredible opportunity for work, and I blew it up. I just blew it up in a very short period of time. I lost a lot of money. I lost the appointment, tons of stuff, right? For several years, I felt an incredible amount of shame. And the shame was less about that experience as it was that that experience ignited the shame that had already been living inside of me. And this is at around, I've got 30 years. I want to say this is around 23 years of sobriety. So the shame that lives inside of so many of us long, long into our recovery, it certainly keeps us from being our truest selves. And it can prolong our suffering. And then it can lead many people to leaving the 12-step community. It can lead many people to relapsing. It can lead to so many things. But that's the power of shame. It leads most of us to take one of two stances, right? This is Terry Reel's work. This is Pia Melody's work. One down, one up. From a gendered perspective, men tend to take the one down position. From a patriarchal or even power perspective, white people tend to take the one up. And I'm sorry, men tend to take the one up, and women tend to take the one down. White people tend to take the one up. Are just two sides of the same coin when it comes to shame. There's no person who projects arrogance or inferiority who's not coming from a place of shame. So that's one of the keys, is that we often don't tend to view arrogance as shame. We don't tend to view narcissism as shame. We see it more as like the one down, where I'm a piece of I'm a piece of crap. I'm horrible. I'm this. But it's been very powerful to see that a lot, well, no, I would say all of the people who have to the need to project this one up persona and this one up degree are coming from a place of shame. And for some, it like has almost calcified into their personality. And for others, it's stuff that gets triggered. Like it can still get triggered in me for sure. As a white, heterosexual, well-educated male from an upper middle class upbringing, I have a lot of entitlement and a lot of privilege that I have to be really careful about. And it comes out, and it comes out in horrible ways, in really surprising ways sometimes, where I'm just kind of like blown away. Where, like, I mean, I can laugh about it with my wife now, but I mean, like, you know, it was just kind of like, holy cow. And this is coming from a guy who considers himself a feminist, and coming from a guy who did 3 years of graduate school, all in feminism and women's studies, because there was no such thing as men's studies. And so it just goes to show how much you can have the intellectual component, but not have the consciousness, the awareness. And when shame and trauma take over, you never know what's going to come out. And it's very powerful. But so that's how shame can kind of pull the strings of our behavior. So much of our shame is rooted in our gender conditioning and the scripts, the scripts we have. Whoops. Whoa. Okay. For not realizing that we have a choice, right? And I'm going to talk a little bit about that. Gender conditioning is a big, big part of the work that I do. It fascinates me. I was trained as a sociologist. I did my master's work. I was the first person to look at the social construction of masculinity in the culture of Alcoholics Anonymous, and it was a fascinating study, and I saw fascinating things. And I see it in our 12-step communities to this day. But so much of our shame is rooted in our gender conditioning. And then shame tells us to keep secrets about who we are and how we are behaving. And those secrets keep us sick. The things we can't talk about, right? And that's what we say in the 12-step rooms all the time is our secrets keep us sick. And there's another saying too. It's a slight shift in from one of my meetings that I go to where it says, it's not that our secrets keep us sick, it's the act of being secretive that keeps us sick. So Brene Brown said this some years ago. She did a lot of her work on women, and then she was challenged to look at men, and she's very open about that was not on her radar. But one of her conclusions in doing this work was the messages and expectations that bring us to our knees are so organized by gender. And that's the water, right? Because a lot of us don't tend to think about that. And that's like when I talk about as a critical sociologist, I've been trained to look at race and gender and sexual orientation and all these different things, class. And I usually will say that gender seems to be one of the most powerful. For one, it's worldwide as far as like how it shows up. It's very long standing, and it's very easy to mix in with what we think is true when we make it biological or we think it's biological. But more than anything, it's these rigid expectations that we have of ourselves and of others that we've internalized that we don't even realize that we are following on a daily basis. We wake up and we are in the gender soup, and we are immediately doing things that are often propelled by our internalized ideas of gender more so than our agency, our own free will, our own thinking of like, this is who I am and this is who I truly want to be. And it's fascinating to kind of see how it shows up. But the other thing is that it's shame that put us in that place when we were kids. Shame usually taught us these rules about being a man and being a woman. And then it's shame that keeps us stuck. Shame about how we're going to look with our peers. Shame about how we're going to look with ourselves, about this, about that. Can I really be my true self? Which is what makes the whole transgender conversation even more fascinating, because the truth is I have yet to meet anybody who really feels that comfortable having to follow the gender conditioning that they were told to follow, or that they had to follow as a child, now as adults, or even as teenagers. So one of the groups, right, is called the man rules, and the other is called the woman rules. And it's kind of like what are the rules about being a man? And in my other talks, I'll spend a lot of time on this with the audience, and I have them name the man rules, name the woman rules, right? Don't talk, don't cry is a huge one for men. And then you kind of unpack that, and then you have like, don't be emotional, don't be vulnerable, don't trust, don't ask for help, always be in control, seek power over connection. Like those are really powerful rules that live inside of us. And sometimes the most challenging men to help are the ones who are convinced that it doesn't apply to them. Because they think, well, but I don't value that. I don't believe in that. And that's the challenge of shame and gender conditioning, and the intersections of those is that they can easily be inside of us, and they can easily control us and our behavior, even when we don't believe in them. And I think there's probably a lot of us, if not all of us, can look at times where we have behaved in ways that are 100% contrary to our values and 100% contrary to who we believe we're supposed to be. And that's exactly how this works. And then in this larger conversation, you have the rules of gender. Now, here in America, we've decided, apparently by proclamation, that gender doesn't matter. And you can't talk about nuances of gender. And certain facts about gender, I guess, aren't facts anymore. But what I can tell you that is a fact is that the man rules are made up and the woman rules are made up and the rules of gender are made up, and they can be very restrictive and they can cause a lot of suffering. And when people just follow them blindly, it can lead them to force others to follow them as well. And when people question them and look at them, they tend to see that there are ways of being that are options that they didn't realize were possible. And the powerful thing about the 12 steps and 12 step groups and personal growth and all that sort of stuff is that they inherently address, to some degree, gender conditioning. So not they don't necessarily address it completely, and I actually go into a lot of detail on that in some of my other talks that I don't have time for today. But suffice it to say, the gender conditioning is very powerful, and when it is rooted in shame, it's very difficult to intervene in. So that shame, and then the last piece about shame is this: that in the space of oppression, patriarchy, and colonialization, shame is used as a tool of systematic coercion, exploitation, abuse, and violence, right? So shame, back in the United States, shame was used to control people of color. Shame was used to tell them that they didn't have value, they didn't have worth, they weren't human. That was all shame. That was all shame induced, and of course, and then used violence and power to reinforce that shame, to hate themselves. And that hate, that racism, that sexism was in the water of our society, and it still is in the water. It's just not as blatant as it used to be. It's a more subtle kind of thing. And then to make it worse, and there's been a lot of studies on this, as shame is internalized by oppressed people, they turn the lies and the narratives of exploitation and violence upon themselves and each other. And that's one of the most horrific and horrible things about oppression, is when you have quote unquote, successfully broken the spirit of individuals to the point that their shame leads them to believe what the dominant voices have told them about themselves and who they are. All right. And so what I'll often say is, this water that I'm talking about, it runs very deep. Do the 12 steps automatically deal with this? They sure do not. Can they? They sure can. But you can't see what you're not willing to look at. And that's just the bottom of it. So it's the difference between having a sponsor on the 4th step who says, hey, when we get to the sex piece, as a guy, or maybe even as a woman, or however you identify, we're going to talk about pornography. We're going to talk about objectification of women. We're going to talk about violence. We're going to talk about this. We're going to connect that to the 4th step. Well, then you're going to have a much different conversation than somebody who takes a slightly different approach, or a significantly different approach, to the 4th step. Are there conversations in the 12-step community that are still fairly toxic, at times? Of course. We're toxic people. We're traumatized, unhealthy people at times. So what's going to come out of our mouths is going to be that as too. Are we vulnerable to groupthink? God bless us, we are. And in groupthink in the recovery community can be as damaging as anything else. And yet, at its best, it can be absolutely amazing, liberating, and the greatest source of authenticity that we have. So it leads us to addiction. So what do we know about addiction? Well, we know a lot about addiction, actually. Addiction is This was by Robert DuPont in the early 1970s, the first director of NIDA. He said addiction is mysterious and irrational. And I love that definition. That's a wonderful, wonderful definition. And it is true. After 30 years of being sober and working in the field and working like closely with guys in recovery and all of that, I think that sums it up very well. It is mysterious and irrational, and God help the people who are out there thinking that they understand addiction and then proposing to people that they have those answers. And I've seen it all. And now we see it on TikTok and there's no such thing as addiction. Okay, that's one of the things we hear. Or alcoholism is nothing more than you just needing to take control and stop drinking. Okay. I mean, it's like these people on TikTok think that what they have is new. They think they're the first person to come up with this idea that you don't need the 12 steps and that you just need to have the willpower and the control. It's like, hello, you think most of us got to AA because we didn't try that first? I mean, like you just go to Bill's opening line to the 12 and 12 in the first step. Who among us wishes to, admit complete defeat? So addiction is a brain disease. Alan Leshner said that, right? That was significant in the sense that it was the very first time that it had been truly stated with the support of research to qualify it. And so calling it a brain disease was very, very significant. It's a significant component of beginning to understand how it worked. Then you have Gabor Mate and his take on addiction. What I like about his is that it's so comprehensive: biological, chemical, neurological, medical, psychological, emotional, social, political, economic, and spiritual underpinnings. That is good, right? Because then it's like there's all these different elements. And as a sociologist, I appreciate that. Addiction is a treatable chronic medical disease, right? Involving interactions among brain circuits, genetics, the environment of individuals' life experiences. A condition involving use of a substance such as alcohol and drugs, or engagement in behavior such as gambling, that the person has strong cravings, unable to stop or limit, and continues the activity despite harmful consequences and distress upon discontinuance. So those things that are underlined, those are kind of the key variables for addiction. Now, I'm not spending a lot of time on this because I'm assuming, there's a lot of understanding already about this. But here's what's interesting that we don't talk about enough, and this is older research, right? This is older research, but it's so important because the public, certainly, but a lot of people in our world still want to view addiction as an acute illness. And when you view it as an acute illness, you miss the incredible significance of that it's a chronic illness. It looks like a chronic illness. It has the characteristics of a chronic illness. And interestingly, when you compare it to other chronic illnesses, it behaves a lot like a chronic illness. We denigrate addiction treatment by saying, oh, there's so much relapse and this person went through treatment this many times. And that's fine in some ways if you put it in context. And the context is that if it's a chronic illness, that's to be expected. If it's a chronic illness, you're looking at the predictive factors for relapse, and then that it's different for different illnesses, right? So who relapses? Well, which are the illnesses that you're talking about? Lack of adherence to treatment, that's one cause for relapse. Psychiatric comorbidity, that may or may not have been treated. Poverty, and then low family supports. And so people have different elements, but this is the same for all chronic illnesses. Lessons learned from chronic mental illnesses. Most patients do not respond to their first treatment or medication. Treatment effects typically don't last very long after treatment stops. Symptom improvement does not continue, and this is the significant piece, right? This is what we in recovery know. Symptom improvement does not continue without behavioral change. But it's the exact same thing for other chronic illnesses. But for whatever reason, diabetes and heart disease are not nearly as scrutinized as addiction treatment, nor are they, though they are much better funded, they're much better integrated into the medical establishment and the medical community, and even teaching doctors, because doctors today still have horrible amounts, or I'll say it differently. They have just a very, very little education on addiction and mental health. And yet they have the ability to prescribe. And yet, when you look at the amount of education they've gotten, unless in med school, and I know this for a fact because of people who have gone through med school and people who are psychiatrists, it's very little education. They are starting to change that. And then you have the whole phenomenon. I'll ruffle some feathers because it's what I like to do. I like to say my intention is to be provocative, but never offensive. Am I freezing up at all? I am. I reset my thing earlier.
Yeah. Just a little there on the for a minute, yeah.
Okay, please let me know because I can't tell.
I thought sometimes my screen freezes, and when I've interrupted, it was on my side. So if it's
let's
on
assume
yours,
it's me. Let's assume it's me, and if it happens, just let me know in case something gets like kind of lost.
Sure.
But here's one of the things. What's one of the big things in mental health and addiction and trauma right now, right? It's psychedelics. Oh, psychedelics are coming back, right? Everybody is, getting going wow over psychedelics, and it's psilocybin and it's LSD and it's ibogaine and it's ketamine. And I've done the trainings and I've sat with the people who came up with some of the very first studies with the psilocybin, and that's all well and good, because I do believe that it can be helpful. But what we're doing is what we always do, and now we think it's a panacea and we think it's a single bullet approach. And here's what I know. I know that using psychedelics to treat addiction, that may or may be helpful. But what I also know is that there has been almost no research about the impact of using psychedelics with people in recovery. And what I also know that really pisses me off is how many people in our community are now relapsing as a result of using psychedelics as part of their treatment. That's being brought to them by professionals, that's being brought to them by peers, that's being brought to them by TikTok and Instagram and all that stuff. And do I think that means like, oh, well, they use ketamine, so they have to change their data? That's not what I'm saying. That's not my point at all. My point is, we have not studied the impact of psychedelics on people in recovery. And we think that they respond the same as people in the general population, which is absurd. I am watching guys relapse who are being told to try this because of their depression, who are being told to try this because of their anxiety, because of trauma, because of this. And what I just keep telling them is, I say, there is absolutely no research right now supporting the use of these psychedelics and the safety of it for people in recovery, especially long-term recovery. And if anybody knows of any research as of now that you want to, share with me after I'm done, that's fine. And I'll be happy to let people know about that. But as far as I know, this hasn't been done. This hasn't been studied. And it's absolutely critical because when you are engaging in the use of hallucinogenics, you are activating the certain parts of the brain that are receptive and responsive to addiction. And so what appears to be happening is that people's addictions, surprise, surprise, are being activated by this. Does it matter if it's done in a very safe, contained, professional environment? Possibly. But I know of situations of both. And I just think there's a whole amount of work that we need to do to truly protect the recovery community in this space. And the reason I bring this up is if we had a really dedicated, focused view and research on recovery and really made that a priority, we would understand better what happens to people, what happens to their brains at around 5 to 10 years. What is this phenomenon that we see happening with so many people? And how might it be related to our brains and our brains settling, stabilizing, changing, this, that? We have done very little. We studied people in recovery for about 6 months, and we think that that's adequate to understand the impact of long-term alcohol and other drug use, the comorbidity of mental health and trauma, and thinking that somehow that 6 months or that year gives us the data or the understanding that we need. There's so much more that we need to do. That's my soapbox. There you go. It's a little intense. I apologize. So here's some of the research that recovery is teaching us, and they are starting to do some longitudinal research, right? Like real longitudinal research and meta-analytical studies that have been looking at AA, but they still haven't done a lot of research on people who are long-term recovery. But here's what we know, greater conceptualization, measurement than in the past years, longitudinal research, meta-analytical studies, overwhelmingly conclusive that AA works. It really does, that there are elements of AA specifically that you can pull out and have in other modalities or interventions, but that AA itself has been shown to be very effective in with certain aspects that's done. But again, like I said, what's incredibly understudied is the 5 to 10 plus years of recovery, brain reparation, comorbidity issues, and all of that. All right, so that leads us to our favorite topic these days, trauma. Everybody's talking about trauma. I've been talking about trauma for almost 20 years. And there were people who, when I started talking about trauma, had been talking about trauma for 20 years. I didn't understand trauma at all. It wasn't on my radar. I was part of the National Recovery Committee. If you're familiar with Recovery Month in September, there's a group that comes together from all over the country and helps come up with the theme and all the activities and all that sort of stuff, advising SAMHSA. I was on that committee for 10 years. We had the folks from the ACE study come and talk to us. We, as a whole, could not have been less interested because trauma just was not on our radar. So it is today. And that's a wonderful thing. And that's a very powerful, powerful thing. And I say that with some caveats, okay? So here's my take. Again, it's not the truth. It's just my take. John Briere, long time, definitely long before me, a expert in primarily child behavioral trauma. He said that if we treated trauma in all the ways that it shows up in all of the patients' lives that come to us, if we treated trauma as trauma, the DSM would be a pamphlet. The DSM, or I believe you all in Europe, you have the ICI, I think, something like that. But it's called the Diagnostic Statistical Manual, and it's the house of all of the mental health disorders that we've come up with, right? And what Briere is saying is that trauma masks a lot of these disorders. Gabor Mate, obviously one of the leading voices today, and you know, I agree with some of his stuff, and I don't agree with some of his stuff, but a lot of it I do agree with. He says, not all addictions are rooted in abuse or trauma, but I do believe that they can all be traced to painful experience. A hurt is at the center of all addictive behaviors. The wound may not be as deep and the ache not as excruciating, and it may even be entirely hidden, but it's there. That's great. Like, I appreciate him saying that. But here's the danger of a comment like that. First off, there are people who have had deeply painful experiences who are not addicted. We still don't understand why, but they're not. And the hurt, as far as we can tell, does not cause the addiction. It might help to create the environment and the disposition for the addiction. But if you read this, you can infer some things.
Seem to have frozen up again,
100%.
Dan.
Okay, thank you. And I really hate this. I'm just gonna go on for a second. I'm just gonna I've got this supposedly fiber cable that is supposed to be the best like in the world, and it's worse than what I had before I didn't have it. This freezes up. I am very frustrated about that, but that's okay. We'll just, it's what's happening. So, a sense of deficient emptiness pervades our culture. 100% true. The drug addict is more painfully conscious of this void than most people and has limited means of escaping it. I love that line. That is beautiful. That is a wonderful description, I think, of people with addictive disorders. Very powerful. And so I want to make it clear, I really respect Gabor Mate and the work he's done. I disagree with some things he says, and I don't know if they're fundamental disagreements or if it's nuance. Talked about the ACE study. You may be familiar with it. I'm not going to spend a lot of time on it, but the ACE study really was the first time in our culture where we operationalized trauma. There was a study at Kaiser Permanente in San Diego from 1995 to 1997, 17,000 participants. Everybody filled out a confidential survey. Then they did the questionnaire, the famous ACE questionnaire. And the reality is that this brought the idea of trauma into the general population. Until that time, it had been seen as something with people with severe mental health or veterans or this or that. But what the ACE study does is it just totally normalizes trauma as being part of our general population. The information was combined with the results of their physical examination to form the baseline study. I mean, they're still mining all of the data, from this because it was such a huge number. And they found some fascinating things. But the most fascinating thing that they found probably was that it's a 10 question survey, okay? And what they found is that there seems to be a point that anybody who answers yes to 4 or more of the questions had a significantly higher likelihood of trauma, addiction, and other challenges kind of as part of their life circumstances. Jamie Marich, who I believe a lot of you are familiar with, she talks about trauma as a wound, and I love it. Right? It's a very simple definition. And when you think of a wound, you think of how a wound heals, how you address a wound, if you don't address a wound, how the community responds to the wound, all that sort of stuff. It all fits very well. This is a definition that I use for a long time, and it comes from Bessel van der Kolk, but with a little bit of added piece from a guy named Roger Fallett, who is really one of the he and Maxine Harris are the grandparents, I guess you could say, of trauma informed care and thinking about trauma informed care. So trauma occurs when an external threat overwhelms a person's internal and external positive coping skills. So trauma occurs, right? So that means you have a traumatic event. It doesn't mean trauma develops, as in like a trauma disorder develops when this happens. It's just this is when trauma occurs, is in this moment, right? And then you see like what are the different things, the different directions that this can go, and like what can happen. Because one, you have these different responses, and this isn't even all of them anymore, because I mean, I think the last I saw there was like 7. But these are some of the most common. But fight, flight, I mean, it used to be fight or flight. Then it was fight, flight, and freeze. Then it was fight, flight, freeze, and fawn. And now it's fight, flight, freeze, fawn, and faint. And the faint is just kind of an elaboration off of the freeze. But because it's a deeply dissociative component, people have been advocating for the use of that. In fact, I just learned about it not that long ago. Somebody took me aside from one of my talks and was like, well, do you use the font or the faint? And I was like, no. I was like, what is that? But then the fawn came up from Pete Walker. He did a great book about childhood trauma, and he saw like that there's this response that children especially have, this fawning that felt like it really needed to be called out, because that fawning is I mean, it's deeply connected to codependency, and it's deeply connected to a loss of self, where the person will do anything to appease an abuser to try to keep peace, right? So you have these 5 things. So here's the thing. Now you have the next thing. This is called a coping strategy, right? You have the trauma response, and then you have the coping strategy to that response. Anger is a coping strategy for many, many people. It's the trauma response is like to fight, because for whatever reason, and it tends to skew more towards gender of males, and then it's anger, and it's a coping strategy. This is something that I find very important, that I don't think people like Gabor Mate and others clarify enough, frankly. Alcohol and other drugs are a coping strategy. Addiction is not. That is a very, very important distinction. And hopefully people understand that, you know, kind of this distinction I'm making, and we could talk about it more when we get to the questions. But, and I just looked at the time, it's 12:25. Okay. So it's just really important to understand the use of alcohol and other drugs to numb the effects. That's a coping strategy. And there are many people who use alcohol and other drugs to numb the effects of trauma who do not become addicted. And there are others who do become addicted. So addiction is not a coping strategy. Addiction is the result of using alcohol and other drugs. And because of the genetic physiological disposition of the individual, they become addicted. I don't hear that teased out enough or clarified near enough. Then you have attachment and the role of attachment. You have, I mean, I love attachment. I could do a whole nother hour just on attachment and how it's changed my understanding of relationships and how I show up in relationships and what I was doing in relationships, and how, you know, trauma just had a massive impact. My childhood trauma had a massive impact on my ability to stay employed, my ability to stay in relationships, my ability to, once I was in relationships, to be intimate and truly connect. And then add in all of the gender conditioning of men, And I will often say that being a man in Western society is its own attachment disorder. We repeat what we do not repair. Then there's traumatic stigmatization. There's all the trauma that happens as a result of people who grow up in poverty, incarceration, from racism and sexism. And does it mean that if you have these experiences, you automatically have trauma? I would say no, because there are people, and Resmaa Menakem is a guy who has done a lot of work around this, that they study the resilience of oppressed groups. And why do they not all act or seem to be, traumatized? And part of it is the inherent resilience of human beings, where it's like, I'm in this situation of poverty, I'm surrounded by supports, right? If you go back to that definition, the internal and external positive coping skills, if I've got some internal and I've got external positive coping skills, I can deal with this stuff. It doesn't make it okay, and it doesn't mean it hasn't affected me, but it might be a lot less traumatic than if I'm growing up in poverty in a family with addiction and abuse and violence. That's going to be much different than I grow up in poverty with a family who is doing the very best they can, who loves us, who is safe, and who takes care of us. Even if I live in an environment, a community that is impacted by violence, there could be the trauma from that experience, but it's multiple kind of layers when it comes to traumatic stigmatization. The biggest thing for anybody is to just simply look at our experiences and say it's not trauma. For our society to look at our experiences and say it's not trauma, and that's the way that we miss it. So the principles of trauma-informed care, these are kind of core principles, and evolve, and these are actually this is my version of the principles of trauma-informed care, where I added mutual responsibility, and I added compassion, and really kind of bringing compassion to this. But there's a whole lot that we can talk about principles of trauma-informed care, but these are the principles that we try to apply to organizations, to the work we do, to the services we provide. So here's kind of some last things. Hey, have you heard about trauma, right? Again, for those of us who've been working in trauma a long time, it's so funny. Like, I've got friends in AA who are like, I don't talk a lot about the work that I do. I try to keep it separate. And so like their therapist is talking to them about trauma or attachment, and they start talking to me about all this stuff. And I'm just kind of like, oh, okay, yeah, that's interesting. So is it a buzzword and a trend? Absolutely. Is that a positive overall? Yes. Is it a negative? It can be when it's done, like number two, in a perfunctory way or dilution, or it's just a buzzword. Hey, oh, I got trauma. Oh my gosh, stop gaslighting me, man. All of that kind of stuff where the language, exceeds the reality of the ability to truly intervene with integrity. The number one thing missing, right, is this. The number one thing missing, and this is, I see this all the time. I hear it all the time. I think people like Gabor Mate, this is where they really shine, is it's like in a lot of presentations on trauma, you will sometimes not hear them emphasize the importance of us doing our own work and our own trauma, and looking at our own trauma and dealing with our own experiences, and just looking and seeing what's there, and not being one of those people who's like, oh yeah, well, that person's got trauma and that person's got trauma, but I didn't have any experiences like that. And it's like, no, just go to a therapist, just talk, just see what comes up and see what's there. And if you're not willing to do that, then don't, then that's your place, but you can't necessarily really say that you haven't been affected, because I alone am not the best arbiter of whether I've been affected of trauma. And that's frankly on both sides. the degree to which I think it's like the most overwhelming thing in my life, and now I've defined myself as a trauma survivor, and that's my identity. Sometimes that needs to be reeled back in, as much as the inability or the lack of willingness to really look at that. But personal work as a fundamental principle of trauma informed care has to be there. In the States, there's a lot of chasing of funding, treating it as trauma as a silver bullet. And that's even led me to develop a presentation called So You Think You're Trauma Informed, where I just really try to do a reset of exactly understanding what trauma informed care is about. I'm going to keep moving. I'm just about out of time. This is a reality check. We are a traumatized world, living with traumatized neighbors, trying to create peaceful communities without doing the work. That's part of it. The last thing is mental health. How am I doing? 12:33. All right, give me 2 more minutes or so. All right. So in our society, especially men, but in our society in general, we're kind of wired for disconnection. And this illusion of connection that we now have with social media is really fascinating, because they say we are the most disconnected population that's ever been on this earth, with the illusion of being connected. Mental health includes our emotional, psychological, and social well-being. It affects how we think, feel, and act. It also helps determine how we handle stress, relate to others, and make choices. Mental health is important at every stage of life. So mental health is just literally an everyday thing. Some people have to pay attention to it more than others, but everybody has mental health. Everybody has mental health challenges. And for some, it gets to a point where they need additional or professional help. The factors that contribute to mental health problems: biological factors, life experiences such as trauma or abuse, family history. It's all of those. It's an admixture of all of those things. In many ways, it's the most overdiagnosed and underdiagnosed. And so it's so interesting, right? So there's some people where it's just like some mental health issues have seemingly been way overdiagnosed. And some maybe not diagnosed enough or at the right stage of time. Like we've very focused on kids, but maybe not as focused as adults, very focused on ADD and ADHD, but not focused enough on trauma, bipolar, other things like that. The diagnosis without diagnosis of an addictive disorder and or trauma, there's still far too many professionals out there who are diagnosing individuals without, and they're just being like, they're not understanding the complexity, which is what this whole presentation is about, the complexity, the elephant of the individual that's coming to see them. And so they're diagnosing without understanding or having the information about their use of substances. Sometimes it comes up, sometimes it doesn't, all of that sort of stuff. The diagnosis is an early remission of an addictive disorder. So that can be a challenge if it's not revisited at like 6 months, 12 months, 2 years, because so much of addiction, as well as early remission of addiction, can mimic and reflect mental health symptoms. Many professionals are still not educated on addiction or trauma, let alone shame, as I mentioned earlier. So it runs very deep. There is a solution. The most obvious solutions are training and education, accurate and ongoing assessment that is comprehensive, braided clinical services where everybody's talking to each other and testing for things, breaking down the silos, cross-sector communication, and of course, our own personal work. I didn't see trauma in anybody else's life until I began to see it in my own and do my own work. And the more work I do, the more I see these different aspects of how these things show up in people's lives. So it's universal. It's a paradigm shift of what is wrong with you, what happened to you, and it's the both and. To me, it's always the both and. It's not about doing it perfectly. It's about doing it consciously. And there you go. That's me. If you're interested, we can talk about this later, but Dan at dangriffin.com. And if you're interested in getting on my list, you could do that with this QR code. I just send out lists or send out newsletters with the work that I'm up to, different messages, resources, that sort of thing.